detail to go over. So we'll get shoving on. We got a few learning competencies. We're going to talk about basically around the policy around this, looking at different ways that finance affects systems. And we are going to look at basically the whole summation of all of these objectives is basically how do we finance this industry, okay? As an individual, how do you pay for your own health care? What are the options available throughout your lives? And then look at some of the details behind those plans and programs. All right. Yeah, we're going to talk a little bit about how the ACA affected us, some of the changes that have gone on, and the ebb and flow of policy, how it's affected just in the last, 8-9 years, what it's done to us. So I'm going to show you some slides here in a little bit. In about 25, 30 slides from now. I'm going to show you, I found some data today. I'd forgotten about this website that talks about utilization, and it'll show by payer source. It's really interesting. You can see when certain things took effect, how changes occurred. So we'll talk a little bit more about that. But if you look at the U.S. system as a whole, the whole financial aspect of our non-system is pretty complicated. We had a conversation in our leadership meeting today at 11. Not that you care what time it was, but at 11 we met and we talked for about 20 minutes about the patient satisfaction aspect of payment. And historically, we've been really good in this area, but we want to make some improvements. And so we talked a little bit about, we changed to a new model for observing our patient satisfaction. And what it's done is it's changed our overall scoring. Why do I bring this up is, the way we're being scored now is more like what you would see through, lack of a better term, a Yelp review. And so that's how we're being scored based on this new program. And that's what we're submitting to the federal government when we work on reimbursement. So it's a little scary because there's more information that could make us look worse than we are. And so we've had to change how we're approaching this because, up to, worst case scenario, we could, if we really screwed up in patient satisfaction, which I don't foresee, we could lose close to 15% of our revenue. That's a big chunk of change. Anybody in here want to take a hit by 15% of your total income or the money that, any type of income that you get? I mean, that's a hard thing to swallow, right? As an organization, and to remain financially viable, we have to address this new concern. Maybe what I'll do later on in the semester, I'll pull some old data from the old program. See if I can make myself a note to pull some old data from the old Press-Ganey program, and then show you a comparison of why these changes really mean something. Because we're using a company called NRC. So that one little segment influences policy in the hospital. It influences a lot of decisions that we make. How we treat people, how we communicate with our patients. This is a really broad-reaching item that in all honesty, we wouldn't have ever thought of as unless it affected our repayment. Okay, so it's really complicated to think of how we're financed because it's not just a matter of completing a service anymore and expecting repayment. So you end up with a lot of public and private modes of finance. You can think of all the different government financing plans that are out there. We're going to get into a little more specifics with Medicare, Medicaid, other programs that the government provides to help pay for people's health and wellness programs. Then you have private pay, which is your insurance, or regular private pay. Someone's literally paying out of pocket; they're self-insured, and those all vary. Now you'll see that the percentage of the population that's insured by Medicare is not the largest segment of the population, but it's the primary piece of reimbursement for most hospitals, because even though you may only get, 36% of your total income coming from Medicare, they still are the largest dictator of policy. And so all of our policies have to follow these federal guidelines in order for us to get reimbursed. So it's really interesting how this plays out. Then you have the investment of the individual along with their insurance company. It's really, really rare to find some plan that doesn't have a high element of cost sharing now. And so one of the goals of the Affordable Care Act was to kind of help us get people coverage, right? Get people to pay for some coverage if they could afford it. Those who couldn't afford it, to try to expand some governmental assistance so that they could have coverage. Because if they have coverage, they're going to use it, right? I'll show you a graph here in a minute. It's really pretty interesting. It's people that gained coverage. So a few definitions. Uninsured. Anyone have a problem with this definition? I mean, this is pretty self-explanatory, right? Someone who is uninsured is someone who's not covered by either private or some type of public pay system, okay? But the really important thing to understand is that as a whole, our government does not require us to have health insurance, even for those that are indigent. They are not required to go sign up for Medicaid. No one forces them to do that. Even though they may meet all the criteria, they're not required to sign up for it, okay? So if you think of this, for example, this whole idea that employers were not mandated to offer insurance to all their employees. And by saying this, with the Affordable Care Act came in and said, look, if you have this many employees or more, you're going to pay a penalty if you don't provide, okay? But some organizations decided that it was cheaper to pay the penalty than it was to insure their employees, okay? So there's no mandate that says that you can't take the penalty, right? I'll take the fine in a lot of cases. In fact, that's what an organization that I worked for did. They looked at it as a cost savings. It was cheaper for us to not provide health care for our employees than it was to take the penalty. So we took the penalty. And that's a very cold decision, but it was a very financial decision to keep the organization afloat, especially in an atmosphere of reduced reimbursement fees. Okay. Did it make our employees happy? No. Can you imagine trying to hire people and say, "Hey, we're not going to offer you insurance. We don't offer you insurance." That's not an incentive to come to work for you, is it? How many of you are working full-time or part-time? Any of you? Okay, so you have insurance. Mind if I ask? You have insurance? Yeah, and it's a big chunk out of your paycheck, probably. or at least it is a chunk out of your paycheck, and it's but it's a benefit because you don't have to pay for the entire premium. The company you're working for pays a large majority of that premium. In fact, I'll give you an example of that. When I was in Arkansas, the company I went to work for, after I'd been working for them for 5 months, they had no backlog of history for their organization. They were a newly formed organization, and the insurance company came to them and said, hey, we're going to have to raise your rates because we don't have any demographic or any other type of history for your organization, and so we don't know how many claims your organization is going to have, and so your insurance rates go up. No claims history, so increased rates. So the organization came to me and they said, okay, we're raising your rates. It was by something almost like $500 a month additional to what I was already paying. And I said, no, thank you. So I basically gave them my resignation. And then they said, how about we pick up the tab? So they did. They picked up the tab. But not all of my employees could do that, right? And so that's when the decision was made by the company to drop insurance coverage for employees because of the cost involved. Pretty crazy, huh? All right. So with our U.S. system, we're not also, like I said, we're not required to join any program. We don't have to take our organization's provided health insurance, but that's our choice, right? And those of us who have ever had to look at government plans know that they only cover specific groups. You have to fit a specific demographic in order to be able to qualify for most every healthcare plan that's offered by the government. They all have specifics, whether it's based on your income or based on your age. Okay. All right. So financing. This is your premium. Okay. We're talking about premiums. Who's paying for the premium? It depends on where you're getting your insurance, right? There may be some type of assistance, whether your employer's paying part of your premium, you pay the full premium, the government has some type of assistance program that allows it to pay for part of your premium or pay for all of your coverage if it's completely through the government. Some charity organizations will donate or form to provide different types of coverages. But the interesting thing you have to remember is that insurance increases the demand for healthcare. Okay, just point blank. So what is this called? When you have insurance and you have it, you use it. Anybody remember?
Utilization.
Almost, but it is utilization. But what is it called when I say, oh, I have coverage, so hey, I'll use it more often? Dr. Brady kind of talked about it with her moral hazard. Yep. So there is an increase in this area whenever people gain coverage, right? And I'll show you a graph of this in a minute. It's pretty wild. But you'll see that there's higher rates in every aspect of healthcare, whether it's inpatient, ED visits, outpatient care, any type of healthcare coverage. If the coverage is there, then people are going to use it. Okay. All right. So if you think about insurance as a whole, what is the whole idea behind it? What's it there for? So insurance is really the idea behind it is its risk coverage, right? We run a risk We know this is something that's analyzed to determine usage, right? So we look at it and we say, what is the risk that I am going to be sick this year? You know, for me, pretty high. January, February, I'm going to get sick. You know, this is 2 years in a row I've had pneumonia. Get it, right? It's awesome. So I have insurance, so I get to use my insurance. Isn't that fantastic? It's kind of like your car insurance, right? They look at your rates and they base it on different areas, right? They look at it and they say, oh, you know, you're a 16-year-old male. What's your insurance rate going to be like? Sky high, right? First of all, you have no history of driving experience, so they have no claims history on you. They look at your demographic and they say, lots of adrenaline, lots of testosterone, and you put, you know, horsepower behind that, and they're going to wreck something. So it's going to cost the insurance company a lot of money because there's high levels of claims within this demographic, and so your rates are high. You know, you hit 25, you get a reduction. You become an old man, you get a reduction. You get a really old man, and your rates go back up. Okay? It's usage, it's utilization, but it's about risk. It's risk analysis. And so insurance is just risk coverage, regardless of what it is. So, for example, in the hospital, I'm the risk officer, so I analyze the hospital for risk to keep our premiums down for our insurance, to keep us from being involved in a lawsuit. It's exciting, isn't it? Everything's about risk. It's because everybody's worried about getting sued, or everybody's worried about having to make a claim of some sort. So think about your health insurance company. They're not giving away for free, right? They want to stay in business. Most of your health insurance companies are not charitable organizations, are they? So you pay them a premium, and they look at you and say, we can take that person's money, put it in a pool with other people's money, and then we look at the risk involved across this population and determine how many claims we think we're going to have and at what cost it's going to be. And if it's less, then we can stay afloat. And that's the goal, right? And as they see that the risk increases, so do the premiums. Premiums go up. So if you look at, for example, when the Affordable Care Act passed, premiums went up. Can you think of any reasons that premiums would go up during that period of time? What happened to the pool of those involved, that risk pool? What happened? It increased. And who did it take on?
A lot more riskier individuals.
Yeah, so one of the specific things in the Affordable Care Act is that those who had pre-existing conditions, their rates could not increase, and insurance companies had to cover them regardless of what they had, right? They would have to be covered. No longer could people with pre-existing conditions be turned down for coverage. Okay, so now I've got all these people in this pool. That's just one aspect. And so insurance companies go, whew, that's a lot of people coming in. We're going to have to raise rates because now we're going to have all these new claims because all these people have pre-existing conditions. And they're trying to stay afloat, right? So that's just one little aspect. There are other aspects that happened, right? We had a lot of uninsured who became insured. No past history, right? So they get lumped into this thing, and they go, okay, we got all these people now, and we don't know how sick they're going to be. Raise the rates. Let's cover ourselves, because if something catastrophic were to happen, you know, we have to stay afloat. It's pretty wild, huh? It's unlike any business in the world. So, especially understanding moral hazard, right? Okay. So, supply side factors. When we think of financing, what do we know about how supply and demand work? What's your understanding of supply and demand? No understanding. I'm just kidding. So think about this: if we have a large supply of something, if we have a high, and we have a low demand, it's pretty cheap, right? If you have a high supply of something and a high demand of something, you meet your needs. If you have a high demand in something and low supply, it's a scarcity, right? And so we end up with someone can charge higher rates for it because if it's value. A great example of this is to think of precious metals. Okay, precious metals. There's a reason they're called precious metals, right? Our streets aren't literally paved with gold, right? Things. It's hard to get to these items, so it's access. Okay, so access to a precious metal is limited. Access to healthcare, if access is readily available, we have a high supply side, then cost should stay down. However, when you enter into the finance realm and you look across the board and you look at procedures, the financial side of this can put limits on the supply because they can control what they want to pay for. So, for example, wonderful colonoscopies, right? Think about the insurance company looking to screen health screenings, right? Looking at health screenings, and they say, we want we want to screen every person that's older than the age of 35. Well, all of a sudden the demand is really high, right? And their idea is that we want to prevent colon cancer because colon cancer is expensive to cover. So can you imagine every person over the age of 35 gets an annual screening? It's just not feasible, is it? It's an extreme cost. So your insurance company says, okay, if you have a family history of colon cancer, your doctor will make a recommendation, but otherwise, we're going to say 45 years old or older. Okay? It eliminates a population of where they have a requirement to get this screening. It saves money on the front end, and also the evidence shows that anybody under the age of 45 really doesn't need to be screened because the occurrence of colon cancer of people under the age of 45 is pretty low. Okay? So they've limited their risk. And in the meantime, supply increases because not that many people are having to. They look at the population and they say not many people are under over the age of 45 that are going to need this. And it may be that you hit it at 45. They say, okay, we see you in 5 years, okay? Or we see you in 2 years. And it depends on your plan. Some insurance companies are different than others. And they may say, no, we don't, with our insurance company, we say 50 and older, and whatever history, okay? So they can control what things are offered based on what they will financially pay for. Has anyone, you don't have to raise your hand, but think about this. Have you ever gone to the doctor and he said, let me see if your insurance will cover this? Exactly, right? It's the availability of that test, for example. So this is how financing limits supply, okay? So knowing this, what type of factors could there be with demand? What could factor in that could cause a need for a supply from a demand standpoint, regardless of financing? So maybe community occurrence of something, right? And so it may dictate that this is a needed procedure or a needed screening. But the fact is that finance affects the supply, the demand, the distribution of all of these services, okay? And one key factor is the type of healthcare professionals that are available. So think about rural health versus an urban area. with supply. So if they look at the financial availability of, you know, what finances are available in an urban area versus a rural area, right? The urban area is going to have deeper pockets. It's going to dictate that, you know, we can afford to have certain specialists. We can have certain equipment because we have a larger pool of individuals to pay into our system. And you look at rural health and you think, okay, we have a small population, which means that we have a smaller income base. And more likely these individuals, their own personal incomes will be lower. And so what their likelihood to utilize services will be lower due to their own financials and their own access. So pretty wild stuff, right? Everybody in here want to be a controller in a hospital now? No? So let's talk about resource-based relative value scale. This is an exciting one. Ready? You holding on? Okay, here we go.
And I'll just say, this might show up.
On an exam?
On an exam.
Yeah, it might show up.
Just might.
This is really, in all honesty, this is a pretty simple program, you know, I mean, not program, but pretty simple. It's one of the simpler reimbursements that are out there, okay? All right, so this is the actual formula that shows how payment rates are calculated for services, okay? And this occurs in a practice, okay? This is not DRG, this is not RUG. This is what your regular practice will look at, okay? So your payment is going to be equal to all of these different things, okay? You have a work relative value unit, and then you have what they call your geographic practice cost index, okay? That's a thriller. And then you've got your practice expense and your malpractice expense, and they factor all of that in, right? And then they look at your area and they say, okay, here's your geography, and they say we're going to multiply this by the conversion factor. All right, so for example, you can look up the Tennessee practice expense, and that's like a 0.9. I haven't looked it up for this year. I forgot to look up 2019 rates. But you would have something like, let's see if I have that on there. If you have, and don't be afraid of this, by the way, on the exam, if it's on there, it will have something like your RVU is this, your GPCI is this, and this is, you know, it'll show you what each of the areas are. You're not expected to memorize any of this. I'm not going to expect you to say, oh, my RVU is a 1.0 and in Tennessee, and my practice expense is a 0.9, and then my what do you call it? My malpractice insurance rate is a 0.525, and then my multiplier for my conversion factor is a 1.35. It'll all be there for you. But the fact is I want you to understand that there are values here, okay? So you have these units that multiply across your practice, and they're not fixed. They will vary every year based on what the government says you can charge. So if you get a chance, go to the Medicare website. I've got it listed down there at the bottom. Play around with this tool. You'll find it's really simple. Probably one of the easier things to understand once you use it. That's what I've kind of figured out. All right, so if we look at the extension to uninsured people, that will increase your expenditures, right? So that's your E. So if your expenditures are equal to your price times your quantity of services consumed, that's what you need to remember, okay? So we're talking about insurance with payment, which that increases your supply or reduces your supply, because moral hazard, right? So remember moral hazard in all of this. What's it going to do to your supply? It's most of the time it will reduce your supply, right? Somebody's filling that slot, for your appointment. I mean, you call your primary care and say, "Hey, I need to come in today at 2:00," and they say, "Of course," right? No, they never do that. They say, "Okay, we can fit you in October of 2022," right? That's how they look at it. Literally, my annual physical is scheduled every year in December, and that's the only time. And then I call when I'm sick, and they usually refer me to an urgent care center, because they say, by the time we get you in here next week, the illness will probably have run its course, or I'll be dead. That's as I cough and hack. All right. Anybody have any problems with this idea of how expenditures are equal to your price and your utilization? No? Okay. Pretty self-explanatory. You didn't know that you're going to have to do math in this class, did you? All right. Let's see. Make sure I've got my notes. So I think we've beaten this to death. We've talked about how utilization, access, and insurance all kind of play a part in supply, and how finance can govern that. Anybody too concerned about this slide there? Nobody? Okay. So how do you control expenditures? If we're increasing our controls, what does that do to our expenditures?
Should decrease.
Yeah, it should, right? That's the whole idea of control, right? We're decreasing expenditures. It's the idea of a budget, So what happens when you expand health insurance? What's the key word, phrase, I guess? Moral hazard, right? So it will increase expenditures. More availability, more access equals more expenditures. And what do we say about things that are not covered? Are they heavily utilized? No, right, they're not heavily utilized. So if you look at the whole insurance function, we've talked about risk. I hope that everyone in here, by the end of this class, understands risk really, really well. It's really important, and I think it's not looked at enough as a major factor in all of our lives. Okay? If you really think about the cost of anything, risk there's a definite calculation to take place because of risk. You go buy a box of Cheerios, there is risk calculated into that box of Cheerios. Okay? Heaven forbid you choke on some Cheerios, right? There's risk involved. So the insurer, another way of saying insurer is the underwriter. What does that title tell you? Tell you what it tells me. It's the person that is dictating the policy. They're dictating my coverage. They're the ones that are literally writing my ability to gain access. Okay, they're the insurer. They're the underwriter. Okay, the beneficiary is me. I'm the insured. Okay. But if I am the only insured, is it going to be more expensive for me? Of course, right? One person. Can you imagine an insurance? I'm an insurance company. I've got one client. So I have one person in that risk pool. And so I say my expenses are very specific, right? So it's going to be really expensive for me. So we have what we call premium sharing. Okay? And as a benefit, my company will also share in the premium to reduce that cost so that I can gain access. So when you pay a premium, what is a premium? It's your fee, right? Yeah, it's your payment. It's what you're going to pay to gain access to that company's ability to help you gain access to coverage, to be able to utilize services. You know, one of the first things that we did when we moved to the area is when we found out what our insurance company was, we called around to get ourselves a new primary care physician. And we had a list of people who were given to us, recommended to us, and we checked with a few, and a few of them did not accept our insurance. Out of network. Don't take your insurance. So, not a good fit, right? Because I don't want to have to go to, every time I go to my primary care, I don't want to have an increased rate. I want to go, I have someone that fits into my policy, knows the services that are available to me, and keeps my costs down. Okay. All right. So there are four fundamental principles within the insurance function. Look at that four-letter word in almost every area of this, right? Risk. Remember, the insured, we don't know what my risk is. If I'm the insured, we don't know what my risk is. You know, I could walk out the door here, somebody's rolling a cart down the floor loaded with bricks and just level me, right? Broken leg. Never know. Get in the car, drive out of here, get wiped out, right? Horrible things can happen. It is unpredictable. But risk as a whole for demographics and for a pool of individuals, pretty accurate. There's a lot of data points involved. So remember I talked to you about the new company I was with. There was no history, so the premiums were high because it was unpredictable. But once you're in with a large pool of individuals, risk is pretty easy to figure out. Especially when you look at geographic locations, you can tighten that stuff in. You know, every year I get into a discussion with some students about demographics and how, you know, this is, you know, it's stereotyping. It is. I mean, it's another element of stereotyping, and that's what it's used for. Stereotyping works for the most part. It's really ugly to think about in a very politically correct world, but it works. You can look at people's ages, their sex, all of these different attributes, where they live in the United States, and know as a whole what's going to happen. I mean, there was I think they just released the recently the top the rankings by state of most obese states again. There's a reason they do that, right? It's not just for fun, and so we have something to laugh about. Hey, I laughed one year because I moved, not one year, I had moved from Georgia to Alabama, and Alabama that year became the most obese state in the country. And then like 4 or 5 years later, 6 years later, we moved to Arkansas, and then Arkansas became the most obese state. So I was starting to get a complex. I was like, is this me? You know? But the fact is, they look at those things because there are health indicators involved with obesity. And so it's very important to look at those. And as an insurance company, why would I turn a blind eye to that information, right? So we've talked about how we pay all of our money in. We may not have to make a draw out of this insurance fund that's there. And we hope we don't, right? Everybody here wants to stay healthy. We hope that we never have to use our insurance, kind of like your car insurance. Do you hope you get to use your car insurance on your way home tonight? Nobody in here wants to use your car insurance on the way home tonight, right? You want to get home, no scratches, no dents, no accidents, no nothing, right? So should you have to use it, the money that your insurance comes. So recently, give you an example. I hit a deer coming to work one morning. I hit a deer. And it knocked out the headlight and damaged the front bumper pretty badly and scratched the hood. And I go and I take it in, and they're like, this is $7,000 and change worth of damages. And I'm looking at this car going, are you kidding? The car's not even worth $7,000. The car's old. It's got like 220,000 miles on it. And I kind of laughed. And so I thought the insurance company was going to total my car. I was like, well, I'm out of a car. You know, and it's not really that bad. I was like, man, I can piece this back together myself. It's okay. Replace the headlight myself. And it was really funny. They said, oh, we'll pay for it. You pay your deductible, we'll pay for it. It's like, okay. Paid my deductible, fixed all the damage, and got the car back. So I paid my deductible, and I've been paying insurance on this car for a few years, right? But I haven't paid $7,000 into this insurance company since we've had this car. So who else is paying for this? Everyone else, right? Everyone else that's part of this premium, part of this policy, okay? Everyone else that uses the same insurance company that I use, they're helping pay for my car repair. It's a pretty good gig. That's good, right? Yeah, I got somebody else to help pay for it. That's nice. All right. So we've talked all about risk rating. We talked about how experience, so it's the history behind it, right? The community rating, that's how much utilization will occur of that service within a population. It does not look at demographics, that part of it, okay? But your adjusted community rating will look at your rates based on demographic within the community, okay? So you see, you're looking at your history, they're going to look at your population, and then they're going to look at your demographic. So if your population has a high incidence of COPD, they're going to say, hey, that could be a factor here. We may have some claims in this area. If they look at your demographic and see that your demographic is a really high risk, they're going to say, hey, probably have to raise premiums here. If you got a really bad history of claims, they're going to look at all three of those things, and guess what? Your premium is going to probably be higher than someone else's. Okay? Deductibles, that's that payment we make, right? So that helps me share in the risk at that point. So some of us may have, for example, when I go have surgery, I may have an initial deductible that I have to pay out before coverage kicks in. So say the surgery ends up costing me $13,000. My deductible is, let's say, $1,000. I have to kick in $1,000, and then after that, insurance kicks in, right? That is not a copay. Copay is just for going in and using that service. And so my copay may be $50, $25, $30, depending on your plan. Then you have what they call co-insurance. Okay, and those are usually 80-20, which means that you pay what? 20%, right? Insurance is going to try to pay that other 80%. And they usually have a limit on what they're willing to pay out or what you will have to pay out, depending on the policy. So an indemnity plan, this is a great definition, and I can't remember if it's on the exam or not, but it might be. Okay, so I would commit this one. But an indemnity plan really pays you for your expenses regardless of who is providing service. Okay, regardless, you can go to anybody. All right, but a service plan is going to require a network. Okay, so think about the type of policy you get. All right. Let's see. So if you look at the total population, this is a little graph from the Kaiser Foundation that shows in 2015 the population and how people were insured. So if you look at the total private insurance, of those who had coverage in 2015, 56% were private, which leaves 36% public. So remember I talked about the total funds going, right? Just because you're covered doesn't mean that you use your insurance or that you're going to have service. More of your public, for example, Medicare is great coverage. I mean, it covers basically everything. You may have a slight copay, which we'll get into in a minute. But really, that's why they're the biggest payer source in a lot of these hospitals. Okay? All right, that's just a neat little graph for it. All right, we've talked about being voluntary. That puts the requirement on us of whether we want to have coverage or not, right? But most of us get our insurance through our employer. You think of your insurance if you're, for example, my brother had a little consulting business for a while. He got his own policies, and it was really expensive for his family because they didn't have a large pool to choose from, right? They don't have a pool of other people in there to help offset that. So you get a discount from having an employer. And as a benefit to you, your employer probably pays 2/3 of your premium. That's been my experience. It's been about 2/3. And it may vary by the organization. Okay? But how can a business be self-insured? And why would they want to be self-insured? So they have really good risk programs in these businesses is what it comes down to, okay? They've evaluated the risk of being self-insured. They realize that they have enough financial means to pay for this insurance for their employees out of their own pockets. And they offer the coverage themselves. And so they look at it and say, we're not going to, we think it's cheaper for us to keep this in-house and just pay for it. Sometimes it's for a benefit, it's an additional benefit for the employee. Sometimes it's just because they are trying to save money instead of going outside of their own organization. A lot of not-for-profits do this. In my experience, they've done that. Lots of really large organizations do this because they have a large enough pool. Okay. Does anybody need a break? You mind if we take a 5-minute break so I can kind of deal with this?
So if you're self-insured, if you have, I guess it's risky though, right?
Very risky. Yeah, it's all on you.
Yeah, but but if it plays in your favor, you cut out the quote-unquote middleman, right?
Yeah.
So it could save you money.
Could save you money, yeah. Yeah, it's why pay for an arbitration? You know, I mean, you have somebody there you have a gatekeeper for you. So yeah, it can save you a lot of money. All right, let's come back. You guys want to come back in about 2 or 3 after 5? Will that work? Okay. All right, so we're going to pretty much fly through these types of insurance. Okay, group insurance covered this. I mean, we talked about group insurance. Covers a large population, right? Self-insurance talked about that. These things mean exactly what they say, right? Self-insurance, you're self-insured. Okay, individual private insurance, you have developed your own private insurance, and it's just for it's an actual insurance plan. Okay, you're not just being self-insured. A high deductible health plan. We haven't really talked much about this, but just about every organization now is offering a high deductible plan. What's the benefit of a high deductible plan? Can you tell I have albuterol in me now and I'm talking a little bit faster? Yes.
Low copay.
Low copay, right? So your cost is lower, and you're evaluating your risk. That's what you're doing. You're saying, I'm not going to get sick that much this year. I'm not going to require anything major. Okay? I'm not going to have to spend. I don't want to have to spend all this money. I don't need to go to the doctor that often, so I am going to take this high deductible and not worry about it. And that way, my annual cost is low, and it's a gamble, right? Okay, managed care organizations. You have HMOs, PPOs, a few others out there. So, you know, do we know the big differences between an HMO and a PPO? One of the primary differences between the two is that, for example, with a PPO, you don't have a gatekeeper. You don't necessarily have to go to a primary care physician and say, okay, look at me, find out that I've got some kind of problem that requires a specialist. With a PPO, I can look at in-network providers and say, hey, I know my knee's bothering me, so I'm going to go to an orthopedic physician and have them take a look at it. Skip out on that other fee. So the benefit is for you that you have less out-of-pocket costs. You're not paying an additional copay. You can go directly to someone that you feel will address your problem more completely. The disadvantage to not having this is for your insurance company, because you may be able to go to your primary and have your primary care provider say, you don't really need to do that. I can just take care of that here, because specialists are more expensive, right? Okay. HMOs don't always offer that option. Public financing, you have all these different programs. You have Medicare, Medicaid, PACE, CHIP, you have military, which is usually those on-base programs or your VA system, and then the Indian health system. Okay. My brother, I have 2 brothers that are in the FBI, and one of them was in South Dakota and was on reservations. And so he had to interact a lot with the Indian Health Services. And it's pretty interesting. I mean, they're their own nation, basically. So, all right, so high deductible plans, talked about that. Short-term stopgap coverage. This is like you quit your job or you're fired from your job, and you assume what they call the Consolidated Omnibus Budget Reconciliation Act coverage, COBRA, right? And this is super expensive, because basically you're paying the entire premium yourself. What it says is that your organization is required to offer you continued coverage if you elect to carry that coverage over until you can get a new job or new coverage, right? And so when you go, so say you lose your job, and they say, all right, well, normally this premium would have cost you $130 pay period. But now you're taking on the entire premium. You're maintaining your insurance. You didn't lose your coverage. You didn't have to go to a new plan, but you're paying for the entire thing basically. So now it's $700 every 2 weeks. Sounds like a great deal, huh? Especially when you don't have a job, right? So it's pretty expensive. So some people like to use it just to maintain, and they have the ability to do that, but most people don't, just because of the expense. Now these Medigap plans, these are supplemental plans. We'll talk about those in a minute. They don't cover things like long-term care for long periods of time, vision, dental, hearing aids. I always found that really interesting. Things that are not covered by Medicare in nursing home settings or by Medicaid. Dentures, hearing aids, but they're all about quality of life being provided. It's kind of sad, actually. Let's see. So if you think about some of the trends, if you look at employer coverage, one of the things that's recently come out is they talk about coverage for individuals that are 55 to 64. Because of the way the market's moving and people in that certain demographic with their job situations, they've noticed that it's harder for them to find new jobs. So they fall out of the system, kind of. They're in that nebulous period of coverage, and while you would think that most people would just jump right on to hiring somebody ages 55 to 64, it's a tough time to be in, because you would think with all the experience that you would have that somebody would just jump right on you. But the downside is a lot of organizations go, they're going to be retiring in a few years. We need somebody for long term. And so they end up falling out of coverage. So they're noticing a decline at this time, during the last couple of years. The private health coverage has kind of fallen in these areas. A lot of these people are having to go on to public plans. And we'll talk about a lot more of these trends. We already talked a little bit about the pay mandate. Basically, if you have more than 50 employees, provide care, face a fee, right? Let's see. How much I want to dig into this right now. Cost sharing. Just know exactly what it says on here. Why would the Affordable Care Act want to limit out-of-pocket cost sharing? It's not a super hard question, right? It's to save the individual, right? Save their money.
What are some of the things that have no out-of-pocket cost sharing in the Affordable Care Act? Broadly.
I didn't even hear you.
What are things that have no cost sharing for the Affordable Care Act?
This is where everybody makes no eye contact.
Yeah. They're on the preventative side of things. So certain kinds of, like your no out-of-pocket costs or low out-of-pocket costs for contraception, vaccinations, screenings. Why do you think there's low cost sharing on that side and higher cost sharing for chiropractic and massages?
Because those other preventative things were things that people need, and that was the whole point of the
Yeah.
ACA.
Yeah, so like you're lowering the barriers. You're kind of trying to make more moral hazard for the preventative side because we know that's the cheaper side. And if we get people using healthcare from a preventative side, then we're going to catch things. We're going to prevent things from happening, which in the end is, having your insurance pay for those services, fully is still cheaper than, an unintended pregnancy or a really bad case of the flu.
Yeah, colon cancer.
Colon cancer, yeah.
Colon cancer. I mean, it's cheaper to catch something like that right up front. Remove a few polyps, and then you're not having to worry about it later.
So it's kind of the opposite side of the controls on that piece. They want people to have access to it versus keeping people out of utilization or underutilizing something.
So here's a little neat table here to show you some of the changes that have occurred. So if you look, this is pretty interesting. If you look at the number of workers, percentage of employers offering health insurance, it's been pretty flat for the most part, except for in those organizations that had 25 to 49 workers. See what happens there, 2015 and 2016. You have a pretty dramatic reduction in those that are offering health insurance for that group of individuals. Now, what was the cutoff? Remember what the cutoff is? 50, right? So you got 50 employees, you have less than 50 employees. What happens? Why would I provide that now? So the drop, we're talking, that's a percentage of, drop from 2010, that's 12 percentage points. That's substantial. Greater than 200 workers, pretty flat across the board, but it did have a reduction. So covered workers, just to give you, is another way of looking at this. Coverage 47%, down from 59%. So this tells you that a lot of people are electing not to have coverage to begin with. All right. 6 main ACA provisions. 26. This is my complaint. Okay, I have kids. I have a 14-year-old daughter. I have a 17-year-old son. I don't mind paying for their insurance. I got a 22-year-old that's out on his own, working full time. I can't deduct him on my taxes, but I got to pay for his insurance. I'm just kidding. I got to pay for 2. It's no different for 2 versus 4. So it's so it's pretty interesting though. What has that done? What is this aspect of the ACA done for young people?
It's helped them out, but
It's a pretty big demographic here when you think about it that don't elect to have coverage. Because these young adults are looking at this going, I am healthy. I don't need health care coverage. What are the chances I'm going to get sick, right? And what do you think the percentage of this population is that ends up in the ED, getting checked out when something happens? Pretty good, right? So it just makes sense to say, hey, it's okay to, you can still carry these guys on your insurance. So it made it illegal also to charge more or refuse coverage for pre-existing conditions. We talked about that a little bit. So the pool of coverage, people to be covered, increased with conditions. Okay, And we all saw this one coming. We knew that was going to increase rates. It's how it works, right? We knew that was going to happen. That was one of the biggest complaints that people had was prior to this taking effect was this is going to raise my rates. I mean, it's an expense. So, but think about this population of people who was not, they were not covered because they just couldn't get coverage because the insurance companies looked at them and said, I'm not touching you. You have chronic condition. I know you're going to use a lot of services. I'm not going to use, why would I insure you? Okay, that's just like me saying, like, here's free money, right? Okay, it's a great benefit for them. And I'm not saying they shouldn't have it. I think absolutely, if you have a chronic condition, this is a public necessity right here, in my opinion. All health plans had to include essential health benefits. So specific items that were deemed necessary for societal health had to be covered. Okay? The exchanges. This has been a segment of the law that has been controversial, right? A lot of problems getting the exchanges up and going. A lot of those involved in the exchanges. A lot of companies dropping out because of the cost. The individuals who were applying for insurance in these exchanges, were a lot of them were costly. And the government says, hey, we're going to place a fee on you for taking part of this. But we want you in here, right? Doesn't that seem a little backwards? Okay. Included a medical loss ratio. Basically talking about how to cover losses, right? And then this is the one that, as of the end of 2018, no longer exists. Number 6. Legal U.S. residents are no longer required to pay a penalty for not having insurance. It was struck down by a judge in Texas. Okay? Pretty interesting. Now, especially since this was where a lot of the funding was supposed to come from, which I always thought was funny. The ultimate goal is to get coverage, but we're going to rely on those who are not going to get coverage to pay fees, pay a penalty in order to help fund this. Ultimately, seems self-defeating in itself, right? So problems that we run into have been high deductibles, expensive deductibles. People don't want to use their coverage. They decided, hey, I can't afford the deductible. I'm forced into paying for a plan that I can't afford to use. Okay. And then a lot of organizations left the exchanges because of the amount of loss they were taking by being involved in the exchange. I know that Unum and United Healthcare, they pulled out of quite a few states' exchanges. Some states were only left with one insurance company in their exchange. So, for example, here's a few that have left. United Healthcare in 2016 was in 34 states. 2015, they lost over $1 billion. And in 2017, they were only in 3 states. It's a big change, right? Aetna announced they were going to leave all exchanges. And then in 2018, they were only in 4 states. I'm not going to go through all of these. Minuteman Health. It's going to pull out of New Hampshire and Massachusetts, and it was a Massachusetts-based insurance. I thought that was interesting. All right. So these are the graphs I wanted to show you. I pulled these up today, and I have the link down here at the bottom of the slide. So when you get a chance, go pull this up. You can compare any two states. You can look at any state and see the types of utilization that have occurred. And these are the different types of payer sources that are being utilized in these settings. So we're looking at ED visits, adult and pediatric grouped together. And you can see that Medicaid has a pretty high running group there for ED visits, right? And then your next highest is your private insurance. And then right down below there, you have your uninsured. All right, and obviously Medicare's down there. These are pretty steady lines, right? This is the state of Tennessee. Excuse me. So let's do a little bit of a comparison here. This is the state of Kentucky versus the state of Tennessee. And the state of Kentucky opted in for the Medicaid expansion. So take a look at the differences in your Medicaid numbers after right there about midway through 2013, right at 2013 into 2014 in Kentucky, and compare that to Tennessee, and then look at your uninsured. So what happened with this population of individuals? Gain coverage. Now I have something I can use, right? I mean, it's pretty impressive. Interesting thing is if you look at Tennessee, they also saw an increase in utilization during those same years, and trending upwards, but not the trend that you would see like you see in the state of Kentucky. I compared this to a few other states that opted in for the Medicaid expansion. All the same. Okay, different population using those services that would not have had those services available to them. So it helped them gain access. And because they have access, they're using the services. So this is ED visits. This is inpatient stays. So this is admissions to acute care. And you'll see that Medicare, highest population here of admission into a hospital. But take a look again at the Medicaid and the uninsured in Kentucky versus Tennessee. Tennessee's pretty much flat, and Kentucky has a big bump and a big drop, right? Because services are available, utilization occurs. Okay. So I thought these were just interesting, a good way to visualize what occurred when access is available, when services are available to someone. All right, so PACE, one of those programs that I mentioned briefly a few minutes ago. 55 years, these are the eligibility requirements: 55 years old, nursing home eligible, medical and social services, and you have to be duly eligible. What does it mean to be duly eligible?
Eligible for those services.
Yeah, I'm eligible for Medicare and Medicaid. Okay. All right. 55 years old, though. Think about that. What's the age for Medicare? Automatic 65, right? Are there circumstances that will allow you to qualify for Medicare under 65? Yeah, of course, right? There's a whole list of things. CHIP, and this is basically coverage for children up to the age of 19. and there is no income threshold. This allows for all youth and children to be covered, but they have to be enrolled in Medicaid prior to this, okay? All right? States cover children and families with incomes up to 200% of the federal poverty level. Okay, so we talked a little bit about federal poverty level last week, just briefly. Did anyone go look at what the federal poverty level is for different size families? It's pretty low. 200% is not a lot of money. Okay? All right. This is one of those areas, by the way, that I go, sometimes it gets under my skin when I start hearing politicians talk about, certain people won't have to pay certain taxes unless they're above 300% of the poverty level or 250% above the poverty level. I mean, 250% is not a lot of money. 300% is not a lot of money. So, but they use those numbers, and people just look at it like, oh, well, that's 300%. Come on, give me a break. 300% of $2. Come on, what is that, right? Yeah. Okay. Military health services like your VA programs and on-base. That's for active duty, retirees, their dependents. And each branch has their own medical facilities. Okay? And when you, so here's the question. If you have VA benefits and or other service benefits, are you restricted only to health care within the VA programs or on-base programs? Can you go to a community hospital and receive services? Yeah, it can, of course, right? And there's not a VA hospital in every town, but there are veterans in every town. And so the arm that is used for that, the federal government's insurance coverage is TRICARE. And it's pretty good insurance. The interesting thing about this, I have a friend who I just was talking to a couple of weeks ago. He's an older gentleman, retired military. He's needing to have a couple of procedures done, and he was told that he needed to get a biopsy done, but that needed to move quickly, and so he asked him to go use his TRICARE benefit and go to the community and find a community physician to take care of it so that they wouldn't have such a long wait time. Now, this is a real world situation that's sad, but at the same time, this conversation may not have happened 5 years ago. So the look into the VA system has been really beneficial in seeing that lots of our veterans were not able to use their full benefit because they were on waiting lists. And so this is a great conversation for a physician to have and say, yes, go use an out-of-network provider to make sure that you're taken care of. Workers' compensation, we talked about this a few weeks ago. This is what your employer covers. Okay, you fall off of a ladder at work, using the ladder correctly, you're covered, right? Break a leg, you're covered. You get run over by the cleaning guy on the floor, right? You're covered. Get run over by those Zamboni machines while they're waxing the floors. It's always fun. The VA administration is the largest integrated U.S. health system. It is massive. Think about every base and every VA hospital and their associated, all of those physicians and clinicians that are associated with them. It's a massive system. They use what they call a global budget, and that's how they keep their costs under control. We could spend an hour talking about global budgets. Okay, but that's how they govern it. They keep it within certain constraints. They have well-defined budgets that say this is what we can and can't do. Let's see, I'm not going to read these slides. Let's go to the next. So Indian Health Services, IHS, these cover American Indian and Alaskan Natives. They have hospitals, health centers, they have schools, they have all these clinics, okay, and it's their own system. And you have to be federally recognized as part of a tribe or be a descendant of a Native American or an Alaskan in order to qualify for this benefit. All right, the big one, Medicare. Part A, B, C, and D. Everybody know the difference? Yeah, Part A, that's hospital and skilled nursing facility insurance. It's going to cover your inpatient stay and then up to 100 days of a well period. A sick period before a well period, sorry. So how long, so if you get 100 days of coverage for your rehabilitation needs after you've been in an acute care setting, they admit you into a skilled nursing facility and you have 100 days, how many of those days are covered 100%? I see it on your face, you want to say it?
Is it 60?
20. Yeah, I thought you were going to, you're right there, right? You said you were closer than anyone else in the room. So
I remember reading it somewhere.
So it's 20. So this is really an important number, okay? If you're in an acute care center, this is very important to understand. If you're in a SNF, this is very important to understand, okay? Wherever you are, this is the number that's most important. Because what happens is this referral coming out of your organization or coming into your organization is going to depend heavily on the last 80 days, okay? Last 80 days, you pay a copay, okay? Daily, okay? It's expensive, okay? All right, so 20 days, free and clear. If somebody's used 16 of those days already, they go back into the hospital. Okay, let me go back. Okay, we'll back up a little bit. When does the 100 days reset? Really important to know this one as well.
Is it after 30 days?
60. Yeah.
There's your 60.
There's your 60. Yeah. But you were closer than anybody else in the room. Okay. And you're halfway there. So 60 days. Okay. You have to be well. No hospital admissions. No going back into another skilled nursing facility for 60 days. You do that, you get 100 brand new days. The world starts over for you. Okay. Okay, so that being said, if you're in day 16, you've used 16 of your SNF days, and you go into a hospital, and the hospital says you're going to require further SNF services, what happens? You only get 4 days left, right?
Then you go to the copay.
Yeah. So what is a skilled nursing facility going to ask? Can you afford to pay your copay? What's your copay, right? Okay. So 135 bucks a day, possibly, sometimes more. I think
Nice hotel.
it is a really expensive hotel to stay in with bad food and bad service. Okay, I can attest to this. I ran these things for quite a few years. So here's what we would do. Okay, knowing that most people can't afford their copays, we would either say, okay, we will put you on a payment plan, knowing that you can pay us over time, because we're going to get you healthy and we're going to send you home, or we were going to allow you just to write it off. We're going to write that off as bad debt. And you know what I get to do? I get to submit my bad debt to the federal government at the end of the year and receive a portion of that as a reimbursement. Okay? So I have an incentive to take these people in who can't afford to pay that copay. It doesn't always work that way. Some people are in day 35 and they automatically have that coverage. Now, what happens at day 100? You've used 100 days, and you still need 20 some odd days of coverage. What happens?
Full cost.
It's all on you, right? And that is not cheap. Okay? So Medicare is great coverage if you only need to use it for a limited amount of time, and that's what it's for, okay? It's for use for a limited amount of time. All right, and a hospital will look at these days and go, okay, they've got this many days. Who do we know in the community that can take these people, can help them? Okay? Really important. Both sides of this, understand that number. Really, really important. And for your organization to be able to, if you are a SNF, to remain viable, you've got to understand that 100-day period really, really well. Your marketing department, all your liaisons need to understand that. You need to have therapists who understand how that works. It's really important because you want the incentive here is to get the person home as quickly as possible. Okay. All right, so Part B, got supplementary coverage. Within this PowerPoint, there is a link to the 2019, and I updated it today with all the correct page numbers, to the 2019 Medicare information pamphlet. It's, I don't know, close to 100 pages, maybe more. That's a heck of a pamphlet to try to rifle through to understand your Medicare benefits. Okay, it's really worthwhile to read this. And every year they change it slightly. Most of the time it's based around the copays. Okay, let me think if there's any other notes I need to jump into. All right, Medicare Advantage plans. Those are your Part Bs, right? Part Cs. Those are kind of your additional coverages. They may cover dental, vision, things like that. So here's the interesting thing about these Medicare Advantage plans. So you can educate your grandparents on this stuff, okay? I recently just had to go through this with my parents because they were thinking about that. They said that their physician said it would be really good for them to get an Advantage plan. And I said, why would your physician say that? And what's the benefit? What is it that they're saying is so important about this Advantage plan, right? Well, it'll cover, I think it was help them with their vision coverage. Both my parents wear glasses. And so it's pretty interesting when you look at this because even though you'll partake in a Part C plan, that Part C plan can place limits or override some of your coverage within your Part A and dictate, for example, where you might go in a subacute setting in order to keep the cost down. Okay, so for example, here's in a short discussion. I told my parents, send me the plans you're looking at. I'll take a look at them and tell you what I think of them. And so they sent me the two that they were most interested in. And I said, okay, here's the problem that I have with this. Having worked in inpatient rehab for years and worked in skilled nursing for years, if you have a stroke, these plans will not allow you to go into an inpatient rehabilitation hospital, which is the #1 location based on American Heart Association, American Stroke Association's information. They've said that that's the #1 location for you to recover, not a skilled nursing facility. Skilled nursing is not equipped to help you get back home in that situation. And this limits that coverage. I said, I wouldn't do it. Those two specific plans, okay? There are plans that allow it. So the point is, they have to be very careful when getting a Part C plan because it will limit some of the services available, okay? This is how financial limits supply, okay? It decreases the benefit. So you have to be really careful. Read the policies. Just because, don't look at all the great things on there. Also note things like skilled nursing coverage, inpatient rehabilitation coverage, access to mental health facilities, things like that. Really important that people are educated on this. So how is Medicare? Okay, by the way, Part D is easy because it deals with drugs. Okay. How is all this financed?
Taxes.
Taxes, right? So if you pay into the Medicare system, you don't necessarily have to pay for a premium for Medicare. Now, that's the funny thing. People don't think about that. You can never work your entire life. Age 65 hits, you can apply for Medicare, but you won't get the benefit without paying a premium. Okay? I think the premium's like $435 a month, which is still a good price for us paying for a single policy, but it's still $435 a month. And usually when you're retired and at this point applying for Medicare, you're on a fixed income, right? So it's an expense. So rule here is pay your taxes, right? So pay your taxes. But that's the benefit. You pay into the Medicare system, you're qualified age 65. Talked about some of the coverage and what's not covered already. Any questions here? I really think go through and look at this this publication. It's a PDF document. It will walk you through a lot of everything. It will walk you through everything. Okay. Yeah, the premium, I looked it up, $437 a month for those who did not pay Medicare taxes. And then the Part B premium in 2019, so it's $135.50 a month. Okay. Now Part B is really interesting. Okay. So let me go back to this slide here. Part B is a really interesting plan. So say you have someone in your long-term care facility, right? And they need, they've had a decline in their condition, and you're required to help them maintain a baseline. You have to help them maintain a certain level of quality of care in their living, right? First of all, what's the primary payer source for those that are in long-term care? Long-term care, not skilled nursing. What's the primary payer source for long-term care? Anybody know that? I don't expect, but take a guess, yeah. There's a good chance you'll be better than your neighbor because no one's picking anything. So what do you think it is?
There's only a couple of choices.
Yeah.
Types of insurance.
Give you a 50-50 chance. It starts with Meta.
Medicare.
No, Medicaid, right? I'm not going to the casino with you anytime soon. Just kidding.
It's probably a good option.
So Medicaid is the primary, okay? And what it is, the reason is because it's indigent coverage, right? And most people, when they get to the point where they need this type of coverage, they ask for assistance. So there's certain requirements by state. You can't have a certain amount of money or certain value, dollar amount value, of property even in certain states, most states, and still qualify for Medicaid coverage. So for example, you have 250 acres and you have a couple of kids and you apply for Medicaid, even though you are living off of your Social Security and you have no savings and no other retirement, are you going to qualify for adult Medicaid? Probably not. Your land's worth too much. And so you got a couple of kids and you think, well, I'm going to need this long term. I'll just deed the property over to my kids, and that way I don't own this property anymore. I qualify for the benefit. Can you do that? Depending on the state, they can do 5-year, 10-year look back at your property and look at the value of that and expect you to pay in the amount of value of that property, what you would have gotten if you had sold it. It's kind of scary. Okay. The other side of this is private pay. Are you going to pay privately for personal care in a long-term care organization? Can you afford that? I will go ahead and tell you the answer to that is probably not. It's very expensive. Okay, so now fast forward. You have liquidated all of your assets. You're maintaining the under $2,000 value. I think that's what Tennessee's is, right? It's $2,000. $2,000 value, and you're keeping in your bank account $1,500 on a continual basis, so you qualify for Medicaid, and you're getting coverage, but you have a slight decline in your health, and you need some type of therapy, right? This is where Part B can kick in. You don't necessarily need to go to an acute care center and have a diagnosis, be admitted, be there for 3 nights, and then discharged back to where you're living. They can do rehabilitative services on a limited basis to help improve your condition under Part B. It's just supplemental medical insurance if you have Part B coverage. Okay, it's really, I mean, it's as an executive director or administrator in one of these skilled nursing facilities, understanding Part B is really, really important because that happens a lot. People just get debilitated. They lose their abilities to do certain things. They might have contractures over time because of arthritis or something. They need some type of therapy, but they're not sick enough to go back to the hospital. So you say, hey, we're going to work them up and do 2 weeks under Medicare Part B. We'll run them through a little therapy. If they have contractures on their hands or something, we'll get them some of those carrots under Part B to help keep their hands opened, things like that, okay? So there is an ability to have some additional coverage. All right. So we already talked about Medicaid. You can be dually eligible for Medicaid and Medicare. It's okay. In fact, if you have a skilled nursing facility, the chances are that you will be a duly certified facility if you have long-term beds. Now, in Johnson City, there's only one location that I am aware of that is not duly certified. They're a transitional care location. They are skilled nursing only. They can only keep you for 100 days, period. That's all they can keep you for, unless you are going to privately pay. Okay? And I only know about that because I used to run that location. And they're rebuilding. They're building a brand new place. They're going to be out of the medical center, I think, in the next month. Nice new place. Right behind our inpatient rehab hospital. So, it's really nice. I'm not going to say anything beyond that. I don't want to get myself in trouble. All right. What's that?
That you're being recorded.
I know. I'm on the record. I can't say anything bad. Yeah. All right. So, and probably some student works there, so that's my caliber. All right. Let's see. What do I want to really jump into on this? So, thinking about issues with Medicaid. So, with the big rollout, with the adoption of the new Medicaid standards and reimbursement, not every state we saw. Tennessee is one of those that did not adopt the new requirements and accept the new payments. So it hasn't been adopted in every state. And so what issues has that caused, you think?
You guys should know this. Case.
get through this slide, I'll give you another 5-minute break. How's that? So that's how close you are.
It was too expensive, wasn't it?
For some states, yeah. Some states thought it was going to be too expensive. They did not want to adopt it because of the cost involved. Most of those states were what? Not the name of the states, but what was one of the constricting factors for those states? No state income tax in the majority of those, right? So they couldn't raise income taxes to help fund their portion of the coverage, because it does. It's just like insurance across in the private sector. You're still having a risk pool, right? So you're increasing the number in the pool, and so the chances of having claims go up. Let's see. One of the major problems are that the people in those states who haven't, where the states who haven't adopted the new Medicaid guidelines or the expansion, they have been in a lot of those states. High deductible plans have become more prevalent, but the people that would normally qualify in that gap aren't purchasing the high deductible plan, so they're still not covered. What are some other issues with Medicaid? Why wouldn't, if you qualify for it, why wouldn't you do it? There's a stigma about it, isn't there? There's a societal stigma that says, do I want to say that I don't make enough money to qualify for this? People are prideful. I'll be honest. A lot of people just don't want to do it. It's a process. There are also those who can't or won't go through the process of applying for whatever reasons. They just won't do it. Okay? So outside of stigma and not being willing to do it, those are probably just your two biggest pieces of and those who qualify for it but are not covered by it. I mean, it may just be that they, too complicated. They feel it's too complicated, whatever reason. It's pretty sad. So, all right. Any questions? Another 5-minute break? I do. I need a 5-minute break. So, come back at 5 after 6. Does that work? How do you qualify for Medicaid? Is this age dependent? It's income dependent, right? It's based on the state and that you live in and what they consider the maximum income level. So it's and the size of the size of the family or the income of the individual. Okay. So if you have a family of 4, you and your spouse have 2 children, and you both work, you may not qualify, depending on your combined incomes. Okay. All right. Single with children, working full-time, may not qualify, depending on your income. You live alone, it's just you work full-time, you may not qualify. Okay? So it's a lot of little factors involved, but it's income-based. Okay? All right. So third-party payers, there's a couple of things to keep in mind. they are going to control. They control access. Okay, they're going to determine how you receive care and how much they're going to pay for that care before you receive the care. Okay? You go to your physician. You go to the front desk. They ask you for your insurance information, right? And they run your insurance. They make you sit in the lobby for an hour for a reason, right? That and the fact that the physician probably has a backlog of patients back there that still need to be seen. So they use that time to check your insurance. They ask questions, right? They give you that little sheet of paper. Has anything, if you've been here before, has anything on your insurance changed since the last time you visited? Because they know insurance plans change every year, just about. Okay. So the understand these different definitions: charge rate and fee schedule. Okay. The charges, that is set by the provider. Okay. So the rate of reimbursement is set by the third-party payer. So and then the fee schedule is an index of charges with fees for the types of services. Okay. The first two things are really important to understand: charges and rates. And the reason is because I can open up my own clinic. I'm a physician. I open my own clinic, and I say, "Hey, you come in, and I put a bandage on your leg, and I'm going to charge you $3,000 for that service that I just provided you." Okay? Awesome. I'm going to get $3,000, right? I'm going to bill the insurance for $3,000, and they're going to give me $3,000. Correct? No, right? The insurance company's going to laugh at me and say, "Really? You put a Band-Aid on somebody's leg and you want $3,000 for it?" For that procedure, the rate that we have established is whatever. You know, here's your 15 cents. Have fun, right? That's how they establish those rates. Now, depending on the type of payer source, they may allow a physician to do what they call bill balancing. Okay? So what they do is they say, "Well, here's your 15 cents, and then they send you, the individual, a bill for $2,999.85, and you're on the hook for it." How does that work? How is that right? Okay, so there is some governance involved, right? Okay, which is why they usually have these fee schedules. And they say, this is what we have noticed is the most common amount of time involved in doing this procedure. And so based on, remember the RVRVSs that we talked about? That's where this comes into play. They look at, takes you this long to do a procedure. These are the tools involved. These are the number of people that are required for this. This is why this is how much malpractice insurance should cover for this. And so this is what we'll reimburse for that service. Okay? Make sense? This kind of governs it all then. Keeps me from charging you, $3,000 for a Band-Aid. All right. So, I don't know, maybe 10 years ago, I can't put a date on it, we entered the realm of prospective payment systems. What is this? What craziness is this? You guys know what prospective payment? What is the idea behind prospective payment analysis? So you're looking ahead, right? You are going to have a patient come in, receive a diagnosis, and they're going to look ahead and see what services are going to be needed and project the cost of that stay based on that diagnosis-related group, DRG, right? So DRG is pretty important. From a DRG, a long-term care or a skilled nursing facility can look at a patient and look at their billing system, which is a resource utilization group. or a RUG, an RUG, and determine the types of services that that patient will need over their stay in a skilled nursing setting. Okay. So these are how you get paid. Okay. You have all these different areas. You know, psychiatric DRG systems. You're going to have outpatient prospective payment systems. Case mix methods. So you're looking at case mix groups. You'll have an index for your hospital or your location called Case Mix Index, which is your CMI. It tells how sick your patient population is within your facility. You got home health resource groups. All of these help you look ahead, okay? Help you see what type of reimbursement you can receive or should expect, okay? And that's just how you look at things now. We employ, for example, when I had a 120-bed skilled nursing facility, I employed 4 what I call PPS nurses, prospective payment system nurses. And their job was to look at every patient in-house, look at their RUG rates, see where they were, and make a determination of where we were going to end up with our reimbursement. Okay? Let's see. Home health, case mix. Any questions on any of this? Right now you're looking at this going, okay, that's great. Thanks for the info, right? But I'm telling you, this is really, really important to understand. So any questions, seriously, any questions you get, you're walking along one day, walking your dog, and you think, oh man, DRGs, right? Call me. I'll help you out, okay? I have no problem with that. I'll be glad to sit down sometime and just walk you through every little question you got. There's so many questions that I still have about these. It's a constant thing. And what happens is, as reimbursement, as this disbursement of funds occurs to different organizations, we've had to redevelop our processes and try to generate different, better outcomes in order to capture our share of this. And because you end up with things like, these next few little items like fee for services. What is fee for service?
Billed separately for each service.
Yeah, you do a service and you can bill for that specific service, right? So fee for service, it's exactly what it sounds like. Okay? But what are bundled payments or bundled charges? What is that? Also known as a nightmare. So
And you have a case on it.
yes, you do have a case on it. Fun, you're gonna love this. So bundled charges, what are those? Anybody know?
You just pay for, they're all combined into one.
Yeah. So you get one big payment and it's going to cover everything, right? So think about this along a spectrum of care. You're admitted into an acute care center for whatever condition you may have. They take care of you and they're on a bundled payment system. They're being reimbursed on this big bundle, right? So I like to consider it like a big bucket of money, right? They got this big bucket of money and they say, hey, we're going to get this big bucket of money for these services that we're going to provide you. What's the incentive? What is the hospital trying to do at that point? They want to keep as much of that money as they can, right? So knowing that, what are some strategies that they're going to implement in order to keep as much of that money in their bucket as they can?
Get you out the door quicker.
Get you out the door quicker, right? I'm going to send you home or I'm going to send you somewhere else, right? Okay. So you're downstream. You are a skilled nursing facility or inpatient rehab or you're a home health organization and you get you get this patient straight from the hospital thrown into your mix, where does the money for your reimbursement come from under a bundled payment setup? It comes out of that original bucket of money, okay? Okay, that's the bundle. It's inside that bundle. So here the acute care center is looking at their big bucket of money and they're saying, ha, man, who's the cheapest downstream to take care of this person? So incentive is to kick them out the door, send them somewhere else that's really cheap, and then not worry about them, right? Oh no, now the government's got a requirement. They got this 90-day readmission look back, and they say, if that patient comes back to your hospital within 90 days, depending on the bundle, some of the bundles may be 120 days, some of them may be less, depending on what's going on with, whether it's cardiac related, orthopedic related. There's all these different bundles out there. Some of them are just being tossed to the side, to be honest. A lot of people aren't trying to get involved in some of these bundles because they're more of a headache to work with than not. But so you want to get your bundle of money though, right? And they're looking at, let's say 90-day look back, and day 85 hits, and that patient goes back to the hospital. Where's the money come from for that stay? Same bucket of money, right? So they've lost all this money. Okay, they were hoping they were going to get past that threshold, and that any additional stays were going to be the result of a brand new bucket of money, right? All right, so if you're in a subacute center or a subacute provider, so home health even, what is your job in order to, how do you stay in business in this type of atmosphere? Because if I'm an acute care center, what am I going to refer to? I'm looking for lowest costs and what else now?
High quality.
High quality, best outcomes, right? Looking for somebody not going back to the hospital. They're going to be able to govern that patient's quality of stay in a way that will prevent them from coming back and double dipping into that bucket, okay? So you start looking across this entire community and you say, they're cheap, we'll send them there. And then they have a bad outcome. And so over time, you're looking at this from a risk standpoint, right? It's just like anything else. It's all risk, I'm telling you, it's all risk. They look across here and they say, that skilled nursing facility is high risk. If I send them there, I know that within their stay, they have a 60% chance that they're going to come back in and have to double dip. So we're not going to send them there. It's not in the patient's best interests, because of what patient wants a readmission, right? And it's not in our best interest to keep us afloat. So I'm going to do everything that I can to prevent that. So I'm going to start looking at other organizations. So it may be that you look at an organization that's not necessarily the cheapest, okay, that has really high quality outcomes and says, we can take care of really sick patients, and in the process, we're going to expect a little more money, but you're not going to have to worry about the double dip. So I have to do a risk analysis here, right? I look at my return on my investment here and go, okay, who here, what's the best setting for the individual? So it really gets it closer to a patient-centered care model, in my opinion. That's an opinion. There's a lot of problems with this. There always are. But if you're concerned about an individual patient and their plan of care, it requires individuals to get involved and look at this whole thing. How do we keep this patient healthy? We're looking at the overall health of the patient. I live in this world. I'm in the subacute world. This is the area that is really difficult, because inpatient rehab, as an example, is not the cheapest location to go. And so we've had to really look at what it is that we do well and how we can maintain our status in the community so that we can keep getting patients. I mean, think about it. according to the AHA and the ASA, we're the #1 location for stroke. What does that tell me? I need to market myself as a stroke facility, right? And I need to have really great outcomes with stroke patients. That's what I need to do. But not all of my patients are stroke patients, right? I also need to look at those, bilateral amputees, things like that, and understand how I can help them and help them understand that we are the location that's going to help them the most. And so then you start getting into the insurance side of this, and you start looking at things like your Part C plans, where, hey, guess what? We aren't covered under that Part C plan. We just know we're not going to get any referrals. And so you have to start thinking about what it is that you do well, okay? So it's kind of a big picture here. You have to really think about what is an outcome. If I want to keep my hospital in business, I got to have great outcomes, because I'm not the cheapest guy in town. So when I say that we're the #1 inpatient rehabilitation hospital in our 130-something hospital system, I say it really proudly, because I go, man, we have created something here that it's a good product, and people need us. They need us because they go home. That's what the job is, right? We want people to go home. No one wants to go and spend the rest of their days in some place that's not familiar and it's not their home, right? Okay. Let's see. There's some we've talked about RVSs, managed care approaches. This is the whole approval process. When you call, when you want to go into inpatient rehab, for example, because this would be easy to talk about, they call and see if you are approved to come to us. And your managed care may say, nope, we're not going to pay for that because it's just too expensive. There are ways around this. You can do what they call a doc-to-doc, where our doctor looks at the information, calls the insurance company's docs, and says, hey, this is why we feel that this patient needs this. They work it out. Patient comes or they don't come. Sometimes a lot of times patients really don't understand their abilities, and they don't realize they can say, no, I am going to go to this location. It's in my best interest that I go there. And so that's always a key factor in this. You have a say, right? You don't have to be just thrown into a location because someone says that's where you should be. You can override a managed care organization if you have to. It just may come at a different expense, okay? We don't have a whole lot of time to go through cost plus reimbursement. I would closely advise you to read about this area. Cost plus reimbursement, it's exactly what it sounds like. Organizations can submit for their costs and then something to keep them viable, okay? And then we've already talked about prospective reimbursement. That perspective is, you're looking ahead, you receive a payment for services, and then they can go through and look through your chart for that patient and say, you know what, they really didn't need that care. And so they pull back a segment or all of your payment. Then you run into problems with claims processing, okay? Rule number 1 is have really great coders. People that understand documentation and can code accurately, okay? Because if you're coding accurately and you have all the pieces there, you will not be denied payment. The worst thing is I hate this example, and I use it all the time, but the worst thing for me is when I get an audit from a federal entity like a RIG or a RAC audit. I don't know if you guys have ever heard those terms. Okay, so RAC audit and RIG audits, they have certain requirements put into place for what your documentation must look like. And if it's missing a technical piece out of your chart, they can deny you full reimbursement for a patient stay. So for example, you have a $36,000 stay. So $36,000 on the line, and you have a team conference, which is a conference of all the different disciplines who come in and meet about a patient and their needs. and determine the date of discharge and other items that they're going to need upon discharge. And not every person that's in that meeting, not every discipline that's required by that meeting to be there signs off that they were there. You may have had all the physical therapists there, all occupational therapists, speech therapy, a nutritionist, your physician, case manager, the whole gamut's there, right? And one person forgets to sign the chart, $36,000 down the tubes because of one signature. So you have to have processes in place to guarantee that you're going to meet those requirements, okay? Claims denials are horrible. Technical denials are horrible. You have third-party administrators. These are organizations like KEPRO, all these TPAs that can dictate an examination of your documentation or of the services that you provided to see if that was a required service. Okay? And they do it on behalf of the payer source. So being Medicare or whether it's your managed care, they may employ certain organizations. They will look at things like, oh, yeah, by the way, you didn't meet your patient satisfaction requirement, and so therefore we're not going to reimburse you fully. You're going to get a cut out of your reimbursement. It's kind of scary. Okay. All right. Fiscal intermediaries. These are groups like CAHABA, who also do the same things. They will look at this and go, okay, we're looking at your documentation, your paperwork, all of your filing, all of your coding, and we interpret it differently, so you will not receive this, but you will receive this, or you may not receive anything. They may also find that they look at an entire diagnosis. And then, for example, in our hospital, we have a requirement by federal law that 60% of our patient population meet specific diagnoses. If they do not meet that, if I fall to 59%, if I have, say, 59% of my patients do not meet these diagnoses as an overall for that year, then I can have reimbursement pulled, my reimbursement reduced, and it's all based on what these fiscal intermediaries find. Okay, kind of scary, right? So the rule of thumb there is, hey, don't drop below the federal required mandate, right? All right, national health expenditures. Let's look at some of these. You got how much we've spent in the United States and are projected to spend as a percentage of our GDP. It's quite a change in 60 years, right? From 5% GDP up to 18.7 projected. So this is straight from CMS, and so that's just kind of a startling statistic, right? We are spending a lot of money. Here's how our healthcare dollars divided up. Take a look at this sometime. It's pretty interesting how if you look at hospital care and physicians and clinics where it's spent, that's a big chunk. That's 52% of all expenditures go to those two different locations. But if you look at things like home health, medical goods, the total amount of money that we spend on dental, it's tiny bits. Okay. So there's these two. I will update this link. This second link, I will have to re-upload this because the second link didn't work. I had to go in and find the new link for it. But these are, let's see here. These are informatics that you can look at, and it talks about how our episodic payments work, and what some of the things that different locations are having to look at in order to keep afloat. Okay, and some plans on how to do it. And then there's some of the other areas you can look at here with, I hate it when the mouse does that right there, right? And this is what's happened over the last few years in subacute, okay? So go through and look at these. This is just an easy way to understand what the majority of the market really is after a hospital, okay? Some of the things they're having to deal with. All right, any questions? Everybody think they have a good understanding who's paying for health care, what services you're getting? Yeah? You're gonna go home and tell everybody all about it? Yeah? Figured you would.
If they decide to listen.
Hey, you know, you can always pull this up. It's recorded on the weekends. Show your friends. It's a great way to spend your weekends. All right, that's all I got. Got anything comes up, call me. Okay?